3, 2, 1. Sir, we are live now.
Okay. Hello and welcome, everyone. I, Raj Sakhrekar, welcome Dr. Choll Kim and all the viewers across the globe for your show, The Vertebral Views, the Spine live stream. Today we have a very special guest, Dr. Choll Kim, and he'll be talking on from hashtags to healing, enhancing spine surgery education through social media. Everyone knows Dr. Choll Kim, but for those who don't know him, Dr. Kim is a Harvard cum laude graduate. He underwent specialized training in complex spine surgery at the prestigious Mayo Clinic. He emerged as an expert in a minimally invasive spine surgery techniques and a pioneer in a laser endoscopic spine surgery. This innovation has transformed treatment for herniated disc, radiculopathy, and sciatica. Dr. Kim trains specialists from around the globe in the safe and effective technique application of computer-assisted minimally invasive spine surgeries, including laser endoscopic spine surgery. He's a former professor at the UC San Diego. He founded both Society for Minimally Invasive Spine Surgery and Minimally Invasive Spine Surgery Center of Excellence. He chairs the Minimally Invasive Spine Surgery Committee for International Spine Surgery Advanced Techniques. With more than 200 publications and presentations, Dr. Kim's imprint on spine care's future is solid. His influence spans from the instrumental design to active memberships in the North American Spine Society, American Academy of Orthopaedic Surgeons, and Korean American Spine Society. Beyond the operating room, he enjoys kickboxing, golfing with his mom, and family vacations. Apart from that, Dr. Kim is a really cool and chill person, and we welcome you, Dr. Kim, for his time here. Thank you, Dr. Kim, and hope to have a good talk with you.
Wow, thank you so much for that really wonderful introduction. Okay, let's see. Let me share my screen. I'm honored to be here and share with you essentially my experience. So the title is From Hashtags to Healing. We just wanted to get your attention. And I wanted to kind of talk about my kind of interest in social media and why I've been using social media in my practice recently. So let me start out with my disclosures. I don't think anything's going to be of significant relevance, but I will try to be as unbiased as possible when it comes to stuff like that. So I guess the first question that everyone's probably thinking about is, why am I using social media in the first place? Because it's not something that traditionally the medical field utilizes. I mean, we don't even like advertising, and we're not very good at it, but it is prevalent. And I personally use it for myself, just when I'm bored, instead of watching TV. So it is out there. And I want to kind of illustrate to you why I use social media just by kind of talking about my journey of the last 20 years and how I got to where I am right now. So way back in 2002, I finished my 20 years of post-high school education. I got a PhD. I went to medical school. Then I did an internship and residency, and then a fellowship. And after 20 years of that, I came all the way back, and for the first time in 2002, I joined this gentleman to get my first job. This is Steve Garfin. Many of you may know who he is. He is one of the founders of NAS. He was the chairman of orthopedic surgery at UCSD, and he recruited me back. I did my residency there, and he basically sent me to the Mayo Clinic and told me to come back. I didn't even have a break. And I told him that I kind of want to start focusing on something like minimally invasive surgery so I can make a contribution to the field, because the UCSD program, like many academic programs, it is an open surgery program, and the Mayo Clinic fellowship was a totally open, complex fellowship. So, I had a pretty good idea of what open surgery was like. And I still remember the day that I saw my first spine case. It was with Dr. Garfin. I was a second-year resident, and I looked into a wound of a big revision case, and I thought to myself, I can't believe people can survive a surgery of this magnitude. We had the paraspinal muscles just stripped off with these powerful retractors, and we had 2 suckers going at the same time with cell saver, and patients went into the ICU post-op. And it was shocking that they can survive a surgery like that. But the other thought that went through my mind is, you know what? I think we can do better than that. And while I originally thought I was going to do either peds or joint replacement surgery, I decided shortly thereafter that I think I should become a spine surgeon. There's a lot more to do here. And so when I came back, Dr. Garfin said, that's a great idea, minimally invasive surgery. By the way, I want to introduce you to somebody. He's from Arizona. He's a little on the wild side, but he does spine surgery through a knee scope. And I suspect many of you guys know who this person is. This is Anthony Young. He is probably one of the fathers of endoscopic spine surgery in the world. And he's got like a little family tree of all these people that he's trained, who's then trained the second generation. He's one of my mentors. And I spent a week with him and then multiple isolated sessions where I learned how to do endoscopic surgery. So the uniportal irrigation environment, just like a knee arthroscopy or shoulder arthroscopy, but through a single channel. I fell in love with that procedure. I call it the LESS procedure. It stands for laser endoscopic spine surgery, which you have to admit, for a minimally invasive spine procedure, that is a very, very cool name. Anyway, I don't want to talk too much about it, but it's basically a uniportal knee arthroscopy. You can see I have the endoscope in the wound through a transforaminal approach. You can also go interlaminar, and maybe we can talk about it during the question and answer session, but you can also use 2 ports to do a dual portal. Bottom line is that it's percutaneous and utilizing endoscopic visualization under continuous irrigation. And you can use many of the same instruments that you normally use, but because it's underwater, you also have to use some specialized instruments. The 2 awesome instruments are, one, the side-firing holmium laser, and the other one is the like a radio frequency probe, like a bipolar probe / radio frequency probe. I use the one called Trigger Flex. In any case, it works through water. And just as a side note, there's a lot of bad press about endoscopic surgery, and one of them is that the laser is dangerous. The laser is the least dangerous instrument that we use. It is very precise. That red light that you're seeing is actually not the actuating laser. It is the targeting laser, unlike a gun. So before you even turn on the working laser, that red targeting laser will identify the tissue. And as long as you know what tissue you're looking at, you can't harm the nerve. The only way you can injure something with the laser is to be confused about the anatomy. It has very low penetration. It's very, very precise. And it's the most precise instrument that we have. It's also non-electrical energy. So think about this. The trigger flex probe and the radio frequency probe and the bipolar probes, they are electrical. And electricity conducts through some tissues and can shock the nerve even though you're not right on it. That happens a lot, by the way. It's usually not a bad thing, but just if you think about it, shocking the nerve can't be good, and you want to avoid that as much as possible. The laser is a photon energy. It's more mechanical. And when I use it, I used to do the surgery with the patient awake. They would feel this tapping. They would say, Dr. Kim, what's this tapping sensation? That's the laser. So it does not conduct like electricity. So it's very, very safe. All right, enough about the laser, but everyone makes fun of me about using the laser like it's a gimmick. It's actually a very important part of the procedure. And it's a tool that if I did not have the laser, I would cancel the surgery. And it's also very cool for marketing and patient awareness. People just have a natural affinity to the word laser. I don't know why. And by the way, the laser is a backronym. You know what an acronym is? a backronym is working backwards. So they somehow figured out the word laser, and it stands for light activation by emission of stimulation of radiation, something like that. Light activation by the stimulation of emitted radiation, LASER. You can see why I can forget that. But whoever designed the laser designed a very cool name. Okay, so without spending too much time about the surgery itself and the technical details, I want to spend a little bit more time about the history and things like that. So a lot of people ask me, like, what is a full endoscopic spine surgery? I'm not talking about a mini open tubular system with an endoscope looking down. I'm talking about using a true endoscopic channel and full endoscopic visualization with irrigation continuously, just like a knee or shoulder arthroscopy. And you can just see the difference. I mean, this is a great surgery. But when you compare it with this, I mean, when I show patients this, it's not even close. I mean, relatively speaking, it's two entirely different surgeries in the minds of many people, including myself, but the goals are the same. Here's the interesting thing is about this. It's not new. It has been around for a long, long time. So I call this the oldest state-of-the-art procedure that I know of, because way back in 1999, Parvis Kambin of Kambin's Triangle published a very important study, a randomized prospective trial that basically showed it works really well compared to microdiscectomy, which is not easy to do, because let's face it, a microdiscectomy surgery is probably one of the best operations that we do. And I didn't list this as one of the main reasons for the obstacles to adoption, but one of them is that it's competing with an already excellent procedure. It's sort of like trying to be better than Michael Jordan. In any case, that study was not even the first study. It was the first randomized controlled trial that made a lot of, got a lot of attention. It was published in JBJS, which all us orthopedic surgeons know is the premier journal in our field. It's hard to get published in JBJS. And then since then, there's been a multitude of publications. So if you just go onto PubMed and type in endoscopic spine surgery, the number of publications is, I don't know, staggering to me. If I see another study on endoscopic spine surgery, I don't know what I'm gonna do with myself. There's over 5,000. Now, if you are trying to ask yourself, how's that compare with other studies of other procedures? XLIF, MIS, TLIF, and microdiscectomy, if you type that in for the same period of time, it's not even as much combined. There's more studies on endoscopic spine surgery than multiple different types of procedures combined, including multiple randomized controlled trials and several meta-analyses. That's when you know you don't need to do any more studies. When somebody decides to do a meta-analysis, there's just too many. Either do a study with like 10,000 people or find something cool to study. That's what I say. Anyway, the whole point of that is that I hear a lot that we need more studies. There's enough studies. That's not the issue with adoption, and people are just not really aware of the number of studies that are out there, in part because, I don't know why this is, but in the US, we only look at US-based studies, and I think that's changing, but we're crazy here. I'm sure you know this by now with the presidential elections and things like that. So now you know for sure. Anyway, if the question arises, does it work? It absolutely, positively, 100% is an effective procedure. It's efficacious, and it should be a standard part of our surgical toolbox, should be part of our armamentarium, but it's not. And the issue is really about why the lack of adoption, because the lack of adoption will affect other things. So really the question is, if it's such a great procedure and it works, Why isn't everyone doing it? And I would say that there's many reasons, but there's two reasons that I think are really important. And this is up for debate. The first in the US has to do with insurance coverage. If insurance companies don't cover a procedure because they can consider it investigational, you're not going to do it because you're not going to get paid. You're not going to push to get it paid, which is dumb, by the way, but that's a separate topic. The second thing is that it turns out this is a very difficult procedure to learn how to do. The learning curve is very, very difficult. And people always talk about a steep learning curve, right? The learning curve has two components. Its slope and its duration. So the worst learning curve is one that is really steep, that lasts for a really long time. It begs argument, what's better, a steep learning curve that is short or a shallow learning curve that is long? I have a preference. I'd rather just chew the pill and get it over with. So I'm a big believer in this. If it's a difficult learning curve, so be it, just make it short rather than making it long and easy. So either way, we don't have a choice right now because no one really looks at the learning curve like it's a problem to be solved. They look at it as an insurmountable problem. Next topic. I hope that someday people will talk about their learning curve like this. That's a very difficult learning curve. I know. I've been thinking about what about it is really difficult. Me too. I think it's these top three reasons, and let's just go down each one and tackle each potential reason, find a potential solution for it, and see what happens to the learning curve. And we'll just chip away at the stone until we can improve the learning curve through a directed effort. If anybody has ever been in a conversation like that, I want them to email me and just go, I've been in a conversation like that. If there's 1,000 people out there watching, if I get 5 emails that said that somebody had a conversation like that about the learning curve, I'll be surprised and I'll have better faith in the world at large. Because right now I just think the world is a funny, funny place. Humans are funny, funny animals, and we do funny, funny things over and over and over again. And climbing the same learning curve over and over and over again is silly. An AI machine would never do that.
Definitely.
It would learn and then never forget because it's one entity, not 1,000 entities. Anyway, this is a huge deal because if you're competing with a really successful operation to begin with, and you want to make an incremental improvement, and that incremental improvement, if you're an endoscopic surgeon, is tremendous, but it's really difficult to show for a variety of reasons. But I did a whole kind of review of the learning curve on multiple different types of minimally invasive procedures. This is in core. It's been a while. 2014. Oh my God, I thought that was like not that long ago. That was almost 10 years ago. For endoscopic surgeries, roughly the number of cases that you need to do to feel like you're finished, that you've plateaued on the learning curve, is somewhere between 35 and 72. Who's going to do 35 cases and screw them up at a high rate and could keep going if you're already an attending physician with a practice and responsibilities to your patients and your staff and your rent? That hardly ever happens. And here's a really good study from the US, Ivan Chang at Stanford, and he did interlaminar, which we thought was going to be easy, and it was 20 cases. That's still too much. Because in looking at trying to get people to do minimally invasive TLIF surgeries in my skin to skin adoption program, there's two kinds of surgeons. If you come and learn how to do a procedure and then you go back and try to do it, and you ask how many surgeons do 0 cases after coming to a course, how many do 1 or 2 and then stop, how many do 4 to 6 and stop, how many do 6 to 10 and stop, etc. Group 1 through 5, you think like there's an even distribution, right? But there's not. There's either group 5, they've done more than 20 and that's all they do now practically, or they're group 1 or 2, they've done none or 1 or 2 and then stopped. There's very few surgeons that have done 20 or 10 and stopped. The reason being that if you do 1 or 2 cases and they don't go well within the first few cases, you're just going to think, this is not for me. I'm not doing this anymore. And if you do it in a hospital and you're the first person to do it, all the other spine surgeons, they may be your friends and they may act like they don't care you're doing that, but they're watching you. And if something goes wrong, it is like high school. They talk about it in the lunchroom. But did you see that case yesterday? It took them 2.5, 3 hours. I do that in 35 minutes. And like, it was a nightmare and he was throwing stuff. It's like that. And so that whole hospital and that whole circle of surgeons, that procedure is poisoned. So that's the worst thing you can do. Now, if you can get through the first 5, 6, 7 cases without a complication, and then you have a complication, it's very likely that you say to yourself, I know what I did wrong, because you have those 5 under your belt and you know how well they're doing. It's like, I'm going to do a 7th and an 8th. There's very few people that will do 10 struggling and struggling and struggling and then go, this is not for me. That hardly ever happens. There's a very few people that will do that. You know who do, what kind of people do that? People like me, that once they decide on something, they are not going to let go and just be relentlessly committed to making it work. There's very few people like that will suffer like that. So 20 cases is too many. A learning curve in reality has to be less than 5 cases, maybe less than 3 cases. And more importantly, the first and second case has to go well. If the first case does not go well, you're unlikely to do the second case. That's my very strong feeling. So why even bother learning, right? I'll give you an example. For those of you that play golf out there, for those of you that don't play golf, don't even think about learning. It is a time sink and it'll suck the life force out of you if you're not careful. I try to be very careful not to make this like work, golf like work, and just use that time to enjoy myself and decompress and re-energize. But I could easily see this game becoming like my work, where I just get crazy obsessed about perfection. Anyway, for those of you that do golf, I think you probably know there's 2 types of irons. There are the blade irons. They're forged from a single piece of metal. That's what the professionals play with. And then there's the cavity back irons. There are multiple pieces and its sweet spot is much bigger. I play with a cavity back iron. But if you've ever played with a blade iron, the sweet spot's much smaller. If you don't hit it right, it is the worst experience in the whole wide world. I mean, it makes you feel like an idiot. But if you know how to hit that well, the ball goes further and you can shape it better, like the pros do. So guess what? Learning how to play with blades is like a learning curve that really is really difficult. There's 2 other sports that have a really, really intense learning curve that's difficult. The other one is surfing. Is anybody try to surf? And the third one is snowboarding. Probably the others are like piano and violin. But there's certain things that the learning curve is really difficult. But once you climb it, there's this like, duh, kind of situation where you're at another level. And I kind of consider becoming an endoscopic surgeon kind of taking your surgical abilities to another level right now. But at some point, it'll be like knee and shoulder arthroscopy. At some threshold level, at some tipping point, if you don't do it, you're going to have a very difficult time with your practice. So at some point, we all have to learn endoscopic surgery. That's the future of spine surgery. I'm convinced of it. And if you ask any endoscopic surgeons that have climbed the learning curve, they will all speak just like me. They won't say something like, yeah, I think so. I don't know. I still do a lot of, non-endoscopic surgery too. I kind of go back. Endoscopic surgeons do not talk like that.
Yeah.
We talk like I'm talking. Like, why would you do that open? What kind of crazy talk is that? It would be like showing up to the Masters tournament with cavity back irons because I'm playing it safe. That would just, Tiger Woods would never do that. And that's kind of what happens. I hope I'm not being overly dramatic, but I want to convey the feeling that this is the real deal. And the learning curve is difficult. So I fall in love with this surgery. I finish the learning curve. I create a cool name for it. And I try to become an excellent surgeon. I go to meetings. I start the Society for Minimally Invasive Spine Surgery, where I have to go to meetings now, and I have to give presentations, and I have to listen to presentations, and I have to talk to other surgeons. That's a really good way to become an excellent surgeon and an expert in the field. And I did all that. And by now I've done 1,000 cases, trying to build up this practice where I do more of these less procedures because I love it. But remember, it's not covered by insurance in the US. So it's hard to get people to want to do that surgery because it's very expensive to them. It's completely out of pocket. So I do 1,000 and I decide that's not it. I'm also going to do one other thing. I'm going to provide an unbelievable level of customer service, going above and beyond. And I'll just illustrate the example that says it all. I give out my cell phone number to every single one of my patients. It's on my business card. I mean, I can't market my practice as a customer service focused practice any more than that. And I actually answer. It's my real phone. I don't have a second phone. So I fall in love with this awesome procedure called LESS. I want to do more, but it's hard because it's not covered by insurance. I try to make up for that by providing an unparalleled level of customer service. And I'm like, okay, the floodgates are coming any day now. And keep in mind, this has been since 2002. I've been in practice for 22 years. I feel really old right now. So over those 21 years, what was the result of those efforts, Dr. Kim? You must be wildly successful. So this one graph says it all. So, and you can change this graph, I think, to anything. So less is my goal. I want to do more less procedures. That's my way of saying, this is my favorite patient, and I want more of my favorite patients. Now, Raj may have a different favorite patient. His favorite patient may be right-sided L5-S1 disc herniations because he loves biportal surgery and he's right-handed and he works in room 3. And in room 3, everything is set up for right-sided disc herniations. And he has so much business that he sends all his left-sided disc herniations to his junior partner. And he only does the perfect right L5-S1 disc herniation. Or he only does L3-4 mobile spondies because he loves single position, prone lateral surgery with posterior percutaneous screws done in an outpatient surgery center. That's all. Anything 4-5 or 5-1, he sends to his junior partner, etc., etc., etc. The allegory, the analogy that I'm hoping to convey to everyone is that, I'm using less for me, but you can use whatever it is for you if your mindset is, I want to improve my practice a certain way, right? Yes. And so you're like, I'm just going to be an excellent surgeon and I'm going to take excellent care of my patients. I'm going to be caring. I'm going to answer their phone calls. I'm good enough. I'm smart enough. And gosh darn it, cats love me. And they will come, right? So look at this graph. It starts in 2017 because this is kind of what I've been keeping track, but I've been in practice since 2002. So this graph goes way out. And if you look at it, you'll see the graph is kind of flat. So 2017 is roughly 10 years of these efforts. SMIS, lots of less procedure practice, excellent customer service. 10 years, 2018, 2019, 2020, 2021. It's just hovering around 10%. and I'm trying to do more. Then all of a sudden, things start climbing up. You see that?
Yeah.
Starting in January 2022, like the slope is like, whoop.
Yeah.
So you're probably
Exponential.
wondering,
we can
I already
say.
know what that is. That arrow represents a very significant event in the history of the world. That's COVID. And literally for the first time in like 20 something years, I was at home for 3 weeks straight with almost nothing to do, pacing back and forth, thinking, contemplating, what's life really about? You know, why am I here? Is it better to be loved or feared? Should I wear boxers or briefs? I mean, everything, right? So one thing I decided was, okay, I want to do more or less cases. Why the hell can I not do more? I want to, I want to do way more than this. And I thought to myself, okay, I think the problem is I need people to know that I'm doing them. And probably I need to offset a lot of negative press related to the endoscopic procedure. I don't know if you guys are aware, but there's a lot of negative publicity regarding the endoscopic procedure for two reasons. One, if you have a procedure that's really, really difficult to do and you try it and you can't do it, most spine surgeons are not built to accept anything other than something's wrong with this procedure. It's not me, it's the procedure. It doesn't work, it's false. There's a name for that. It's called cognitive dissociation. And at the same time, there was this really powerful marketing program by a company called the Laser Spine Institute. I'm sure if everyone's heard of that, they went out of business, but they started out using endoscopic surgery, but they quickly went over to mini open surgery and then using the laser for the radio frequency ablation. And they had a powerful marketing program and it had a very negative connotation with the word laser because they leveraged the word Laser Spine Institute. And they were wildly successful for that period of time because patients in the US and probably the world do not look favorably upon traditional spine surgery. So they'll do anything to find something new and different. I mean, we have very bad PR. So spine surgeons look very poorly on the anything that talked about laser spine surgery because they either had a very bad experience during the learning curve and this very prominent negative publicity, very prominent marketing program that had a very negative effect on our outlook. Just imagine patients coming in and say, do you do laser spine surgery? And you say no. You're going to have to say something. You're going to have to say no because it's dumb. You're not going to say no because I'm not good enough. So I decided, okay, I think I'm going to do something to increase the awareness. So I decided I'm going to start making videos of my surgeries and giving them to the patients so that they can share with their friends and family. I'm going to post them to YouTube, and then I'm going to post a few times onto social media, right? So look at this one parameter that I'm going to add in. That parameter is the number of videos that I have on my YouTube channel, roughly. So in January 2017, I don't think I had any. Then I have 12, and then I have, I'm just adding them all up, not per year, but like total number of videos by January 2019 is 39. I have 100 videos total by January 2020. Then I doubled number of videos during COVID because I decided, I had time because I wasn't nearly as busy. And two, I decided this is going to be my way to kind of start marketing and start testing things out. And it directly correlates with the number of videos. Now, this is a great oversimplification. There was a lot of things going on there, not just the total number of videos, but the type of videos and the messaging. And predominantly, the messaging is related to providing educational content. I call it edutainment because you also want it to be non-boring. Now, here's the interesting thing about this whole social media campaign effort. I have a PA who's young. She's my muse. I run everything by her because she's in the social media world and consumes tons of social media, just like everyone in her age group. And then I have finally hired a marketing person who's also same age. And basically, they want me to do lots of like personal things, like a day in the life of, and what's your favorite color, Dr. Kim? And I'm like, I hate that kind of stuff. But turns out those pieces get a lot more views than my educational pieces. So one of the things that I learned about social media is that what patients want to do is two things. Number one, they want information. Patients are just hungry for information from a credible source that keeps their attention, because keeping their attention is difficult. I mean, if you want them to be informed, you can give them a textbook and say, read this textbook of 400 pages. And if you really care about your care and want to be informed, read that and you'll be informed. No one will read that book. As important as it is to them to understand, they will not read a 400-page textbook. That's an extreme example. They need the information in a non-boring way. And so not only do they want information, though, when they choose which doctor to go to, it's sort of like choosing a restaurant. You don't want to go to a place that is completely mysterious and unknown to you. That doesn't happen anymore. I almost always look at Yelp or Google reviews. I've also talked to maybe a friend or two, or even on social media, I saw about it. And I want to go and look at pictures of the place. And if I see the owner's picture in there, it's even like, oh, that's the owner. It's like they must really care. And then pictures of people in the restaurant having fun. So if I was trying to decide between two restaurants of equal reputation and food, and I had to pick one, and one restaurant had a strong social media presence and the other one had a weak one, I'm just going to pick the one that has a strong social media presence, simply because of this feeling of familiarity. And so I think social media is not just for marketing, it's just to help people make the informed consent decision on choosing you in the first place, simply by just seeing you like in everyday life, like they would see you in the office, and getting an idea of what your personality is like, what your speaking style is like, etc. Because there's no such thing as a good doctor or a bad doctor. This is the most likely thing is this whole thing of similarities. I'm sure you all know about mimicking. You know, the FBI, when they try to negotiate with a hostage taker, one of the things that they do is they mimic the behavior, the voice, the speech, the volume, the hand gestures, to make the other person feel like, I'm really connecting with this person. I feel like this person knows me. If any of you don't know about that, you should look that up. It's just all over the internet. It's like a way that like those street performers mess with your head. It's very powerful. And people naturally pick the people that are more similar to them in many ways, not necessarily more knowledgeable, although you can't be you can't be dumb. You have to have some knowledge and you have to convey it in a professional way. But that's probably the most important thing. That's what I took out of my social media presence. And when patients come and see me, new patients, it's not one of those awkward, like, nice to meet you, Dr. Kim. I wonder if you suck or if you're going to be great. They've already decided that I'm great. Because if they didn't, they wouldn't be there. It's a self-selecting prophecy. So my interaction with the new patients is just totally different. And that's what the importance of social media is in my practice. And now the number of less procedures that I do is about perfect. It's about 30%. I bet you it's closer to 40% now. I don't want it to be any more than that, but like now I'm going to move on to my next favorite procedure, MIS TLIF, and then my next favorite procedure, cervical disc replacements. And I just want to get really, really good at those three procedures, like really excellent, so that everyone I touch with those three techniques do well. At least in phase 2 of my career, maybe phase 3, I'll go back to like the Rambo academic, I'll take care of anything. If you're scared of it, I'll do it kind of thing. That was phase 1 of my career. I don't know what phase 3 will look like, but phase 2 is done that. Now I just want to do the easy things from the comfort of my living room couch. with just these delicate Asian fingers. And I don't do windows, that kind of thing. And again, it's an allegory to whatever you decide. I want to do more deformity. I want to do more revisions. I want to do more infections. I want to do more tumors for those crazy people out there. So summarizing all this, if it wasn't for social media, I'd probably still be a really excellent minimally invasive surgeon, giving out a cell phone number and bending over backwards to provide unsurpassed patient care, and still go, why can't I get more or less patients? Or why can't I get more of these favorite patients of mine? And social media comes in, and now it's like too much. Need to put a pause on less cases. I'm getting bored of just doing one case. So if that's what you want to do, and I can't imagine somebody not wanting to do that, have social media. And then there's a bunch of secondary benefits that came out of it, like improving patient education. So I'll give you one example that illustrates that to the extreme. My preoperative clinic appointments, the appointment that they come to a week before their surgery, where they do a full H&P and sign all the forms, I have a video that I made. It's 22 minutes and 54 seconds long. Can you imagine? I have to do that every single time over and over again, how boring that is. And I bet you I never do 22 minutes. I probably just last 5-10 minutes. So it's really complete. By the way, I did this 22-minute and 54-second video in like 1 or 2 takes. No practice, no script. I just sat down at a table with like the packet, and I said, roll. Because I've said this so many times, it's so boring. But now I make every patient watch it. I will not go into a pre-op room until they watch it. I give them a big grief if they don't want to watch it and act all sad, but they watch it. And I walk in and I go, how's the video? Any questions? And half the patients go, no, no questions. And we just chit chat about important things. And I get to know the patient, and I mainly build rapport, get them to like me, let them know that I care and that I'm going to do my best taking care of them. So don't sue me if something goes wrong. That's the deep reason I do that. And I do care about my patients because I give up my cell phone number to them. And I only remember the patients that don't do well. All my patients that do great, it's like, who are you again? My patients that don't do well, I remember them for years. I can't help myself. I'm just wired that way. So it's not like I'm being altruistic. I just can't help myself. So it greatly decreases the amount of downtime that I spend saying the same thing over and over and over again. So I have a bunch of patient videos on exercise, the importance of exercise, what injections are for, like a description of each procedure, as well as the informed consent video. And my patients seem really happy because it's not written material. They hate the written material. And they don't want to see it from some actor. They want to see it from you. For some reason, it's like, that's Dr. Kim talking. Ha, 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 look how funny he looks. He looks a lot older, or like he looks a lot better on video. You know, it's like that experience. The other thing is that my staff are happier simply because they have a resource for patient education. But you know what the other reason is that first patient appointment, instead of the patients coming in kind of like a little suspicious, wondering like, are these guys going to suck? Or are they going to be good? Because a lot of people are like that. They just decide like, I'm going to like this, or I'm going to not like this. And then you get a Karen in there and they don't like it. Ooh, it's going to be a long day. So you just, right? You just want them to show up. I've already decided. And when you have a strong social media presence, the vast majority of the people that come have come because of your social media, and they've already decided that you're great. And so they're really happy. They come to the staff, it's like, I recognize you. I saw you in that video. Oh, you're so hilarious in that video. And they treat my staff much better. And all that gives me a lot more quality time. So more private pay patients doing a procedure that goes home the same day, less rounding. So whatever you want to do to improve things in terms of your efficiency, less time talking and explaining to patients, less time trying to make staff happier. And so now I have, when I tell my colleagues this, they think I'm crazy. Every Friday is admin. That's why I'm here, without stressing out my schedule. So every Friday, I'm the only one that can schedule into my Fridays. because I just do what I want to do. And if I want to do a webinar, which is awesome, I do it without being totally stressed out about like delaying clinic and rescheduling patients. I do important urgent surgeries. I have my meetings, I have my brainstorming sessions, I have my I don't save it for midnight and on the weekends. I also take one full week. The first full week of every month is for admin. Same thing. No one schedules into that. Now, it gets scheduled, but it only gets scheduled with the most high profile thing. Something that is just like, oh, that's my admin day. Is this admin worthy? So looking back on it, some of the best thing that's ever happened occurs during my admin time, because important things can't wait. And important things need your full attention and your highest level of cognitive ability. So this whole process has greatly improved not only my home life, but the quality of the work that I do. And looking into the future, we all build up our practice through the process of word of mouth, right? Our patients and our close colleagues in primary care and our referring providers, they get to know us. They tell them about other people, right? Word of mouth. That's still 50% of the way people hear about me, I think. It's probably going more and more towards social media now, but 50% used to be, and that's probably for most people. Social media really is the same thing, but turbocharged in addition digital format, because it's still patients talking about their experience, and it's a way for patients to kind of take me for a test ride by seeing what I'm like. And so all my social media is really focused on just me being me, talking about things that I really believe in, trying to make videos that I can use to educate my patients, while at the same time making it so that I don't have to repeat myself. And secondarily, they get to know what I'm like and decide, is this somebody that I can trust myself, trust the most important possession that I have, my health. Can I trust it to that person? So you can tell, I think this is a very important thing, and I encourage everyone to do something. You don't have to do a lot like me, but to do something where you have a presence that just simply has the final outcome of conveying to the public the type of person that you are, because that's the type of patients you want. You don't want somebody that is like, oh, we're like oil and water. You want patients that are be like, we could have been friends in another life. So with that, thank you for your attention. I hope I didn't ramble too much. Thank you, Raj, for having me. It was a real honor. And this is such a great medium for communication and sharing of information. I'm really privileged to be a part of it. So thank you. And if you want a little bit more detail about what all this looks like, check out my my YouTube channel. There's a lot of the videos on surgery, on techniques, video shorts, etc.
Wow, that was terrific talk, Dr. Kim. Is lot practical in today's practice, and all the spine surgeons, not just young, but every surgeon should follow the things you just said. It increases the familiarity towards your patients. They feel they are in your safe hands. They feel more comfortable, because overall they feel they know the surgeon well, they know the staff well, and they come up with the premeditated mind that this surgeon is going to take care of me very well. And overall, you showed with the literature that over the period of time how your practice has improved because of the increase in the familiarity with the social media. So just few questions about the same. Going forward, how you feel about the medical profession and the social media going forward in future years?
Well, I think it'll be almost like having a good sign in the front of your building, telling people which office to go to, because you can virtually visit any place in the world now, and Very few people aren't going to do that first. So I think I've already said it. You have to have something. And I would consider your website a social media platform if you configure it in a manner where people can get to know who you are. And you have to have video. And I think you have to have your staff in there, and you have to have your patients commenting to round it out. It's not that difficult. I do everything on my iPhone's video. I have like a mic, a wireless miking system for when I'm in surgery, but it's simple, and people don't want production grade video necessarily. They want something that is raw and real and spontaneous and with as little editing as possible, because they want authenticity. They want credibility. So if you can find somebody in the office, it's usually someone young, and promote them to the level of, you're my senior medical assistant and social media outreach coordinator now. Here's a raise, and I would like you to start helping me do this. It's very, very easy. That'll be the future. So there's no right way to do it. And right now it's still early, so that you can do it very easily with very low cost. And I bet you everyone has somebody in their office that consumes a lot of social media. Just find the person that's like, turn off your TikTok and get back to work. That's the person you want to promote.
Definitely.
That's a very bad message, though. You know what I mean? It's like, you lazy bum social media scroller. I'd like to offer you a raise and a promotion. That's what's going to happen.
Looks like that's what the time needs, because you reach more number of people, you have better outreach, and you can get to know people around to improve overall the quality as well as the familiarity. Going forward, considering the surgeon aspect too, you had a very long curve, or you're doing endoscopic spine surgery over almost 20 years. What advice you would like to give to the young spine surgeons where they can reduce the learning curve and get more skillful with a less number of cases?
That's a very good question, and I think I have a good answer for that. Few things. Number one, when you do your first case, do not take your OCD medicines. You want to be unbelievably obsessive compulsive. You want to triple check everything, and you want to be like me. I check my car alarm 2 or 3 times before I come into work. I get out of my car and I set my alarm, and then I walk down to the edge of the parking lot. I'm like, beep. I'm like, okay, I said it. And then I get past halfway to the parking lot. I'm walking. I'm like, beep. And I go, I definitely said it. That's how you want to be. By the way, somebody saw me do that and started making fun of me. I was walking and he goes like, I think your car alarm is set. It's like, yeah, I know. I can't help myself. You want to be like that, and people are going to think you're crazy. But for your first case, do not take your OCD medicines. Second thing I want to tell you is you got to think not just like a surgeon, but like an interventional radiologist. So surgeons have this powerful need to see everything anatomically to know where they are, right? But just think about what an interventional radiologist can do. They know where things are in 3-dimensional space radiographically using 2-dimensional images. Well, if they can do it, we can do it better because we know what the 3-dimensional anatomy looks like. So you have to get into the mindset. I'm also an excellent interventional radiologist, and you practice it like a sport or a musical instrument and get good at it, right? But you can't get past not being an excellent interventional radiologist and knowing where you are in 3-dimensional space using 2-dimensional images, right? Converting a 2-dimensional world into a 3-dimensional world. And then the third piece of advice is go learn how to do the procedure, start to finish, step 1 to step 10, all 10 steps, skin to skin, start to finish, from a surgeon that does a lot of them, that you can trust and relate to and be able to ask questions. And then when you go back, do not change one single thing. Do it exactly the same way for 5 cases. And then on your 6th and 7th case, then you can make some changes. Because what I noticed is spine surgeons are not only, well, spine surgeons are unbelievably competitive. They're unbelievably single-minded. They think they can do anything. They think they can do better. And they're incredibly creative, and they want to change things immediately because they think they know better. So there was a period of time where people say, well, like, could I do it like this instead? And I said, I don't see a problem with that. This is mostly for MIS T lifts and X lifts. Then I found out they had trouble. I found out from what, and they had changed one step and something else got screwed up that I didn't anticipate. And I'm like, oh my God. So now I just beg people, don't change one single thing. So the 3 things are: number 1, be obsessive compulsive. Number 2, become an interventional radiologist as well as an excellent spine surgeon. And 3, for your first 5 cases, do it exactly start to finish the same way that somebody taught you how to do it. And you'll have to take notes because people will not have a start to finish written out technique guide. I don't even have one yet. That's on my list of things to do. Item number 553. So those are the 3 things before you do your first case. Now, those are the 3 things to do during your first 5 cases. Before your first 5 cases, before your first case, practice on a cadaver, start to finish, by yourself, without any hiccups whatsoever. If I had to guess, that requires you to do the procedure start to finish about 3, 4, or 5 times. You can do that in one day, but you want to do it in a setting where it's you, one cadaver, one X-ray tech, one circulator, and one surgical assistant. So the circulator is somebody like me. The surgical tech is your rep that's going to rep you when you do your first case. One cadaver, one radiology tech, no other surgeons in the room. The first time we do it, I say things like, okay, no, that looks bad. And you get through the first and you ask me questions. The second one, I go, all right, not bad. Start to finish by yourself. Try not to ask me a single question, and I'll try not to say a single thing. Most of the time, it's like, I'm sorry, I have to say something. Because if you don't change this, you're going to screw this up for the rest of the case. And then the third case, like the percentage of people that ask me a question goes down. By the 4th case, down. Very few people have to do 5 cases on a cadaver.
Yeah. Makes a lot of sense.
You can go to the courses with multiple people. You can kick the tires. You can play around with the instrument. But before you do your first case on a human being, do a one-on-one cadaver lab. They're easy to find. You just have to ask for it. And you spend the whole day there. You become friends with the surgeon so that even before your first case, not only have you practiced start to finish, you can take a picture of the imaging studies with your phone, send it to your surgeon and go, Choll, this is my first case. What do you think? And I'll look at it and go, sounds good. Watch out for this, this, and that. And then after the case, how'd it go? Oh my God, it took me 2 hours, but otherwise it went great. And I'll be like, I'm glad you not give up. Don't rush. You can keep somebody asleep for hours. It's worth the extra amount of time on your first few cases. Time is not the most important thing. Doing a thorough job, meticulous job is more important because you're going to get faster. But if a patient wakes up with an inadequate decompression or you're slightly off on fluoro and you scratch the exiting nerve root and give them the postoperative radiculitis, if you do that in the first 5 cases, you will no longer believe in endoscopic surgery. If you can get through the first 5 cases, you will believe in it and you will not go back. That's my thinking on the future of that.
Wow, that was fantastic answer for all surgeons who wants to take the endoscopic spine surgery in their practice. Pretty much practical and how to go about it. As we all know, currently the Uniportal is been getting converted into the unilateral biportal endoscopy. So I learned a lot of Uniportal earlier back in Germany with you and in Korea currently. And Now I'm learning UBE techniques. So considering all the literature, all the discussions with the Uniportal, you feel there is limited vision, that the instrumentation of the Uniportal is a little cumbersome because they are pretty much long than the routinely used by the spine surgeons. Also, if you like to do the fusions, then the you have to work through the cannula and pass the instruments from the viewing cannula and the working cannula. Even the fusion techniques, the cage has to go through the same cannula. And UB came up with a new technique where you work with the working portal differently and the
Yeah.
viewing portal differently. So
Yeah.
it looks more versatile, more precise, more accurate. So what's your take on uniportal versus biportal technique, Dr. Kim?
I'm really glad you asked me that, because we have been talking about uniportal versus biportal. I would like to have a conversation where we don't have to distinguish between uniportal and biportal, because I think the more important thing is that it's endoscopic under continuous irrigation. And so I would like to see it mostly be endoscopic spine surgery. And let's face it, one portal is half as invasive as two portals. So if you want to be the most minimal invasive as possible, you do uniportal. But if you need to go biportal for any reason, then you go biportal. So I would like to see a system where you don't have to choose between a uniportal or biportal. You just choose an endoscopic system. And in situations where you think, okay, I'm going to start biportal, I'm going to start uniportal because I want to be as non-invasive as possible. And depending on how things go, convert to a biportal approach as I go and just make the second biportal approach trajectory in the most optimum place for that particular procedure. So you don't necessarily always have to start out with one or the other and stick to it. A system that basically allows you to do both. That's really easy to do. So I feel strongly that the future of endoscopic surgery is not uniportal versus biportal, but a world where we're going to utilize both. So for example, I've done a lot of uniportal endoscopic fusions, and the discectomy and implant insertion is challenging because it has to go through an 8mm working channel. That is tiny. And you can put 2 implants in there, do it through a biportal technique, which is what I've been doing lately. But even the end plate prep is limited. I want to be able to get not just the cage track, but the end plate and the interbody space adjacent to the cage. And to do that, you have to be able to angulate your instrument. It's very difficult to angulate the instrument through a unilateral portal with this endoscope in there. So having a secondary channel that's unrestricted, it's like having an open portal. So I think it's huge. I mean, I hope that more companies develop a universal system that is both uniportal and biportal. And
Makes a
I'm
lot of
trying.
sense.
We're
Yeah.
working on that with eloquence as we speak. But I've noticed even eloquence, having somebody like me pushing this, they're reluctant because they spend so much time being uniportal surgeons and biportal surgeons. They have a hard time embracing it because the human mind is a very powerful thing.
Yeah,
But that's the
makes a lot of
future.
sense.
It'll be like shoulder and knee arthroscopy. It will be strange to do certain spine surgeries any other way.
Makes a lot of sense. So the future directives to the UB technique, the biportal. So one of the drawbacks of the biportal, you can't do much of the dural work, intradural work. There is dural tear or intradural pathologies because one hand has to be always has to show to hold the endoscope as a viewing portal. So with the future directives, one of the professors I'm working closely with, we are trying to build a grip or hold to the viewing portal so that you will have both hands as a working hands and not just as a viewing portal. And these are the things we are working
Yeah,
on.
I'm glad you brought that up. So one of the ways to tackle the learning curve is to identify technological strategies to make things easier. And the uniportal strategy has not changed in 20 years. It is the same endoscope, same cannula, virtually all the same equipment and instruments. There's very few. I mean, just recently we started developing articulating curettes and probes so that we can work in the peripheral edges. But that's just like in the last 2 years. This has been around for 20 years, longer. And the endoscopes all look the same. I mean, they look identical practically. And so same thing. I'm trying to push the people that I work with to improve the cannulas, improve the endoscope, and modernize it so that it's not so difficult to manipulate the instruments. Because right now, to be a really good uniportal surgeon, you have to be able to manipulate the cannula and the endoscope with one hand. I mean, it's like playing a concert violin. It requires an incredible amount of practice, and it doesn't need to be. It's not a musical instrument. It doesn't have to stay looking like a Stradivarius.
Looks pretty much promising.
Like a Tron, right?
Yeah.
So, to start working on fine-tuning and improving and making incremental cumulative improvements to the technological side, combined with technological incremental cumulative improvements on the education side and the patient indication side and the pre and post-op management side. All those things together is how we get a procedure to get really good. Just think about how good we are with ALIF surgery. If somebody introduced ALIF today and I said, oh, we would think they're crazy. Like, what do you mean I need a vascular surgeon to do the approach? I don't need an approach surgeon to do my surgery. It's like, for this you do. I'm like, okay, I'm not that into it. And then put 2 pulse oximeters on each toe. It's like, why do you do that? It's like, in case the circulation to one of the legs gets interrupted. I'm like, what? I'm not going to do that. Right?
Yeah.
Moving the vena cava and the aorta way over. But it's a great procedure because we've gotten great at it. But a lot at the beginnings, back in the day when we weren't so scrutinizing about new technology, there were some tragedies. So,
the highest chance of the vascular injuries with the ALIF, even the XLIF and the LIFs had a lot of parasympathetic, sympathetic chain injuries leading to the psoas paralysis as well as quadriceps anterior thigh.
So we have a lot of runway to take not only endoscopic surgery, but minimally invasive surgery in general to a level that open surgery enjoys. And everything will be done through some minimally invasive strategy, in my vision. I could go on all day about this, as you can see.
Thank you very much, Dr. Kim. It was really amazing talk and learning from your end. A lot of practical aspects of it, how a spine surgeon should improve his practice, his richness, his familiarity, and outreach. We learned a lot today, and from OrthoTV and Vertebral View Show. Thank you a lot as you gave a lot of time to our show. Thank you very much. Hope to see you soon.
Thank you for having me.
We can go offline now. March